So our speaker today is Professor Madhu Pai. He is the chair of the Department of Global and Public Health at McGill University. He's asked me to keep this short. I will just simply say he is a leader in the field of public health, and in particular in two areas. One is the diagnosis and treatment of tuberculosis, especially in vulnerable populations around the world. And the other is really being an important voice for global health equity. And so we're really fortunate to have you here today. Dr. Pai has already taken advantage of opportunities to meet with people, and he had the rare privilege of being able to actually see the only tsetse fly colony in North America. So in lieu of that, we won't be giving you an honorarium. But we also won't ask you for any documentation or paperwork. So please, Dr. Pai.
The slides working? Yeah, okay. Good afternoon, everyone. It's such a privilege and honor to be here. It's the first time ever at Yale. Normally this would be a stressful talk to give. I'm speaking from experience, but I feel very safe with you. And I know many of you in the last one day that I've interacted, and even before, that many of you are thinking a lot about what I'm about to say. So in some ways, you are ahead of the curve, and I feel very, very safe in discussing these issues with you. A talk like this should never begin without a positionality statement, okay? You should know exactly why I'm even qualified to talk about some of these issues. Somebody once, on my face, called me a double agent in global health. I hated it initially. I thought that sounded bloody sinistrous, right? I think they meant this in a nice way, that I came from the global south, but now I'm living in the global north, and therefore I had some magical divination abilities to understand both worlds. I resisted that label, but over the last 20 years or so, I've come to make peace with it. I am a double agent, and I know it brings lots of privileges to me. The ability to even speak on this issue is a privilege. But it also puts me in very awkward situations. I was just discussing that with Brian Wall earlier today. I'm no longer sure who I can speak for anymore. Do I speak for India? Do I speak for Canada? I don't even know what I can say or cannot say. But regardless of where I came from, which is a small town called Vellore in India, where I lived for 30 years, if you ask me today, I will unhesitatingly tell you I'm one of the most privileged people on this planet. Why? Full professor, male, chair of a department in one of the richest countries in the world. There is nothing about me which doesn't reek of privilege. And I will tell you for the sake of this talk, you and I are the same. I'm you, you are me. We are critiquing each other here. So I'm not here to critique you, I'm critiquing myself. So everything that follows equally applies to me. And you can ask me questions and hold me accountable. And I will tell you in what baby steps I've taken to act on what I'm about to show you, okay? So I don't exempt myself from the critique that follows. I am very much a part of the global north industrial complex of global health, okay? I'm not magically standing somewhere here and talking about what's happening here. No, I'm 100% baked into the system that we are about to critique, okay? Right. So, conclusion slide. You can leave after this. I've learned the hard way not to bury the lead, right? Always give people the conclusion and the start. Global health has a very long tradition of failing on equity, again and again and again. We'll see examples. Why is that? My guess, I could not show it to you in a research study in the New England Journal, but my informed guess is that the field itself is structurally inequitable. And I argue a structurally inequitable field can never truly solve inequities. Okay? It's like a structurally racist institution cannot solve racism. It is simply not possible for that institution, regardless of how good individuals are, it is not designed to solve it. We, you and I'm including myself here. That's why I'm going to be using the word. Anytime I use we in this talk, Take it that it's me and you, okay? We, the global North privileged elite, dominate every single aspect of global health, even today, as we did in the colonial past, even today, as of 2024, correct? To bring equity, I would humbly propose that we have to really rethink what our role is. I would say we cannot be leaders in global health. We can only be allies in global health. Because the most privileged people, in my opinion, cannot be the ones to solve problems on the ground, right? Inherently, we are not designed to solve problems that are very far away from here. And the more privileged and elite you are, the less and less you have the ability to solve problems that are far away from you, okay? To bring equity, not only do we need to shift from saviorism to allyship, we have to confront some of the serious obstacles to allyship within our institutions, including what we just discussed. If you can't even pay an honorarium for somebody in Liberia, that's the kind of structural issues that we are all facing with, okay? So, global North, though, as much as we can shift power, or try to shift power here, is only half the story. Global South is missing here. What does the Global South need to do to bring equity in global health? In my opinion, they need to rise as the true leaders of global health. And that will not happen at Yale or McGill or Canada or US. Similar conversations need to happen in Liberia, in India, in South Africa. I was very lucky to have the exact same talk happen in 2 African countries, Kenya and South Africa. They blew me away with their discussion, okay? They let me speak and they ignored me afterwards. It was all about them talking about what they need to do to reclaim control over their destinies, okay? And if any of you really have the courage, you should listen to what they have to say about us, okay? You're not gonna hear it in these rarefied environments. You need to go there and honestly ask them, what do you think of what we're doing? And they have lots to say about us, okay? And this is the tragic story of inequities in global health. The COVID vaccine inequity probably is the most egregious I can even imagine in my life. But people like our friends like Greg Gonzalez will tell you, oh yeah, we saw the same damn inequities with HIV medicines. So what's new? Look at Mpox. I could have gotten my kid vaccinated for Mpox in Montreal. The whole of Africa had 0 doses, right? And then Stephanie Nolan writes a piece that new sickle cell therapies will never be available in Africa. Of course they won't be. How? We couldn't even get a vaccine there, let alone sickle cell therapies, right? Here is the sad, long history where global health consistently prioritizes you and I over black, brown, global South lives. There is no debating this at all, not after what we saw in the COVID story, okay? There is no place to hide. Our greed, our ability to hoard vaccines and products and not care about others is absolutely pathological, and it's a recurring pattern. It is not a one-off story. It's the same pattern that happens again and again and again. So then why is global health inherently equitable? Global health is this fascinating dichotomy that none of us can resolve in our heads. If you ask anybody studying global health, even an undergrad student, they'll say, yeah, global health is really about fixing inequities in health. At the same time, we never discuss the structural inequities within the field of global health. Why is that? If we really care about fixing inequities, then the structure is also open for critique, isn't it? Right? Could we magically catapult to solving inequities and ignoring the structural inequities within the field? How is that feasible? Right? And because we have that blind spot, we continue to make the same mistakes we do. Now, I have this cartoon that I made like 2 years ago, okay? If somebody asked me, who are the dominant people in global health? When I say default setting, without intentional intervention, without deliberate planning, everything in global health defaults to these people. I see myself on this slide, okay? I already told you I'm on this slide, and I will tell you right now, every one of you is not in this slide, okay? Who dominates global health? Global North people like you and I, white folks, men like me, and people highly educated, Yale Yale MDs, PhDs, McGill MDs, PhDs, Harvard, London School, Oxford. This is the phenotype that dominates global health. Now, if any of you are saying, oh, I don't buy this, well, let me show you data, right? After all, I'm in a school of public health, right? After all, I'm an epidemiologist. Here goes. Where are the biggest global health organizations headquartered in this world? Just stare at the map. I'm not going to spend too much time on it. Who is running these organizations? Virtually all of them are run by Global North men. Okay? Who is serving on the boards of these organizations? We're talking about Gavi, Global Fund, Gates Foundation, all of them. Predominantly Global North folks. In fact, Americans and British nationals alone occupy 50% of board chairs across 200 global organizations. Can you imagine the power that we have? Just by virtue of being on those powerful boards, we can dictate funding trajectories for the next 100 years. We can make life or death decisions that impact people far away, sitting in Seattle, Washington, D.C., Ottawa, London, or Berlin, okay? Where do all the global health dollars go? There you are. Much of American dollars go to American institutions and contractors. Much of Gates Foundation dollars go to Global North organizations. You and I are the #1 recipients of global health monies. And then, as Christina showed us, we have to resort to all sorts of shenanigans to move that money to where it finally needs to go. Okay? I'm not expecting an honorarium. Don't worry about it. This is more than me, okay? Who's publishing? Study after study after study after study shows the exact same thing. The dominant first authors, you and I. Dominant senior authors, you and I. It doesn't matter which field of global health, which journal of global health, it doesn't even matter. UCSF, where I trained, UCSF Global Health Institute, did an audit of their own publishing. They found exactly the same, and they published it in BMJ Global Health. I want you to look at Yale Global Health papers and look at authorship patterns without knowing a thing. I will tell you it will be the same. There was another massive study just published, Coloniality in Patterns of Authorships by UNU University. Exact same findings. Who's editing? Me. You. We are the gatekeepers of knowledge in this world. Dominant beyond dominant. Global North, mostly men, mostly American and British men, edit most of the scientific global health journals in the world. And this isn't me saying, study after study after study shows that, okay? Look at this paper, which critiqued Lancet. I was so impressed. Lancet invited a critique of itself. 200-year history of Lancet, right? I was talking to a colleague there who was a Lancet reporter. Lancet editors-in-chief, over its 200-year history, all white, all male, all educated exclusively in European institutions, have had great influence in setting priorities in research, methods, medicine, and health. Published a week ago. Where are the global health degrees offered? Here. Yale, McGill, Emory, Harvard, UCSF, right? These, and for who? Look at the tuition fee. An average cost of a North American master's in global health is $66,000 US just for tuition. You may not even get a visa. That's a whole another story. Right? You can't even afford the tuition, let alone come here. Where are the conferences held in global health? Oh my God, the devastating visa issues that we spoke about earlier today. I mean, if the head of Africa's CDC couldn't get to a conference, where is the hope for you and I? Right? I mean, this is insanity. Montreal kept away, Canada kept away Africans out of an AIDS conference in the year 2022. I have no words to tell you what that means. We're basically saying, come for our global health event, but if you are not there, it's okay. Right? That's exactly what message we are sending. Canada is a basket case right now for visas. US is a nightmare. UK is downright hostile. I'm wondering what is left now. right? After Montreal, they moved the conference to Australia, for Christ's sakes. AIDS conference. I'm like, are these guys not even seeing what's happening on the ground, right? It was devastating for us. That's an actual picture of empty chairs at a plenary panel in AIDS conference in Montreal. Actual picture. I don't know what we're doing. But the bottom line summary of all of this is that you and I hold enormous power and privilege in global health. And to approach this field without a deep appreciation of our own power and privilege is a massive mistake. To paraphrase Peter Parker, great power comes with great responsibility. Are we even aware of our privilege? And if we are not, that itself is a privilege. Only the most privileged in the world don't know that they're privileged, right? So when I teach global health at McGill, and I teach the biggest 101 global health course every fall, my entire first lecture is this. I want every McGill student to know that they are learning global health or engaging in global health from a place of great power. And that differential needs to be in their thought process in every single way in which they engage in global health. Now, you may say, just for the sake of discussion, somebody asked me once, so Dr. Pai, what's wrong if we are dominant and we make all decisions in global health? We are smart. We are trained at McGill, Yale, UCSF, Berkeley, right? Harvard, London School. We are compassionate. We are kind. We are well-meaning. I grant you all of that. Not for a second am I debating your intentions. You are coming from a very good place, as am I think, right? But that does not protect us from making really bad mistakes, because our privilege totally blinds us to reality. The more privileged we are, the less we are likely to get things right, right? It is the person who is most impacted who will get things in a second that you and I will not be able to see. It's like men sitting here and making decisions about women's health. What the hell do we know about it? And yet, men have made massive decisions that impact women in this country, right? How do you explain that? It's the same phenomenon here. So I can think of many reasons why this is problematic, but I'll ask you to look at the last one. We will make mistakes. The COVAX initiative is a stunning example of an initiative cooked up by global North people, totally naive to the realities of the global South. And as much as it tried, it failed to achieve vaccine equity, right? What would a genuinely global South initiative would have looked like if it had come from the grassroots, from the global South? That's a question we should have asked. And I'm summarizing all of this to give me a guidepost of where we should be frame shifting. I humbly propose, based on everything I've told you, our current model of global health is the first column. We see global health as a charity case, donation of vaccines, aid, philanthropy. We will come and save you one day. Just wait for your turn, right? The vaccines will come, maybe 2 years from now, but wait. HIV medicines did come to Africa 10 years after it was available here, by which time millions of people died. We could stay on in that model. In fact, your government and my government believes in that model, right? Because it's power for them, right? I will withhold aid from you if you don't play ball with us. That's how your government and my government looks at development assistance. What our Global South colleagues are clearly articulating, you just need to shut up and listen to them for once. And they've said this. Article after article they've written during the pandemic saying, we are sick and tired of this charity model. We want to make our own damn vaccines, right? Just get off, give the damn recipe, we'll take care of it, right? No, we didn't. We didn't back the TRIPS IP waiver. We hoarded all the vaccines. We still don't have a pathway for manufacturing vaccines where it's most needed, right? They've said this any number of times. They're saying it is not a matter of charity, it's a matter of human rights. If you have a right to a vaccine, I have the same right. Why? Because health is a human right. End of discussion. It is not a question of how charitable Americans or Canadians are feeling today. We need, as a matter of rights, our own things that we need to survive. They're also talking about reparations. They're saying, what about all the damages we've endured? The only place I'm seeing reparations being discussed is climate change. Who caused the climate change? You and me. In fact, America is the #1 contributor of carbon emissions, bar none. Okay? So this country owes a lot to the global south for the climate change, for the crisis, right? That's what they're saying. Autonomy, respect, self-determination is a word they use all the time. Not only global south colleagues. You speak to any indigenous colleague, that's the first thing they tell you. We need to self-determine our own agenda. No indigenous person in Canada will engage with me if I don't respect their rights for self-determination. Because we messed around too much, and they have been treated so badly, they have zero trust left in us, right? So how do we shift from column 1 to column 2 is what you and I should be debating within these rarefied corridors that we are privileged to walk in. And if you ask me, do I see any role for myself? The only role I see for myself, with great clarity, is one of allyship. I will not be solving India's TB problem. Indians in India will be solving their TB problem. But if they invited me, I could be their ally. Ugandans will have to solve their malaria problem, not you, not me. But if they invited you, you could be their allies. Indigenous communities in Canada will have to solve their mental health and suicide crisis, not me. But if they invited me, I could be their ally. So we can have a theoretical discussion on allyship. There are courses being taught on anti-racism and allyship, even though DEI is under attack all over the world. But instead of giving you a theoretical discussion of what allyship is, I thought it would be very illustrative to just talk about examples. This is an example of failed allyship. It's not a good example, right? The global north had the opportunity of a lifetime to save millions of lives during the pandemic if we had done the right thing. We could have just given the vaccine recipe to anybody who ever needed it. We could have changed the face of this pandemic. We didn't, okay? And so when the Africa CDC chief says Africa must take control of its vaccine manufacturing to protect against a new pandemic, that is the articulation of African leaders that we should be listening to. I was in South Africa in December. I cannot tell you how many African leaders came to the podium at the ASLM conference and said the same thing. We have to listen to them. They are saying, we do not want your charity. We want to make our own stuff and save our own people, okay? Listening to them and acting on their desire is an act of allyship, right? Because they're articulating and telling us what they want. So now, we still can be allies right now as we speak. Why? Because the pandemic accord is being negotiated. And guess what our wonderful governments have done? Yours and mine. They've gone and deleted all equity clauses out of the damn pandemic agreement. Look at this Lancet cover. Far from making amends, a handful of powerful countries, code, US, UK, Canada, EU. Same countries that do this devastating stuff again and again and again. Your governments and my governments. Powerful countries are sabotaging the best chance to translate the lessons from COVID pandemic into legally binding commitments that will protect us all. So if this is how the pandemic accord is going, do you think the next pandemic will be any different from what we saw in COVID? Do you expect even one thing to change? I will tell you right away, Canada will hoard vaccines again. Why? Because fundamentally we've changed nothing. In our attitude, our governance, nothing. Will US continue to protect big pharma? 100% yes. Nothing has changed. You can't afford medicines in your own country. Forget equity. Right? We can't afford medicines in Canada. How are we going to fix this? Big pharma industry and governmental collusion. That's what's happened. Canadian policymakers were lobbied so heavily by big pharma, they pretty much killed the TRIPS waiver. Right? So this is where we are. Advocacy for conference equity. I mean, I can't tell you how much advocacy we did to prevent the AIDS conference disaster in Montreal. Thankfully, IAS woke up and said, okay, we will do a global rotation of our conference. One conference in the global north, one conference in the global south. To me, if you're calling any conference global, if you even use the word global in your conference, this to me is the rock bottom expectation. One in the global north, one in the global south. If you're going to consistently hold global conferences in the United States, you have no idea what global means, because you've already knocked off millions of people from your conference. How do you call that global? I kid you not, they were going to have a tropical medicine conference in Toronto. Tropical medicine conference. Of course, we are tropical for 2 weeks in a year, aren't we? I'm like, guys, what is wrong with this picture? I'm not understanding it. Who do you expect to come to Toronto for a tropical diseases conference? What does it even mean? Malaria conference in Lausanne. I mean, we've lost our heads. We're basically saying, we will talk about a disease that primarily kills you without you in the room. Right? We've got to wake up and ask ourselves, what is our modus operandi? Who do we want in the room? You want an AIDS conference without Africans? Is that what you want? Because that's what happened. Male allyship. Now I'm addressing all my fellow men in the room. We have a lot of work to do as men. Women in global health, Women Lift, have published millions of articles saying that, guys, women dominate the global health workforce. And we are not even at the table 99% of the time when you make the biggest decision. So they're saying, guys, lean out. You've too leaned in. You've taken up all the real estate. There's nothing left for us. Okay? Pass the mic, or better still, just get the heck out of the room, is what they're saying. I'm paraphrasing them. Okay? I have a very strong wife who's telling me exactly this at home. Okay? And I have a very sassy 16-year-old daughter who's giving me hell already. Okay? She lectured me on patriarchy the other day. I kid you not. She's 16. I don't know what they're teaching in schools these days. Anyway, I've written a piece on male allyship. There's going to be a whole panel on male allyship at the Women Lift conference in Tanzania this week. They are wanting, and I don't know how to support them with this, they want an army of male allies in global health. That's what they're wanting, okay? And they're saying it's not enough to mentor women anymore. You need to sponsor women, which is qualitatively very different from mentorship, okay? Lots of work to be done in this area. Journals. Man, if there is one thing I can speak with some conviction, it's journals. Because I had done a study, which I showed you earlier, showing how skewed global health journals are. And then I get an invitation from PLOS to build a brand new global health journal. So I said, here's my paper. Okay? If you want me to do that journal, will you let me fix what I myself have published on? They said, do it. Then I said, if that's the case, 2 editors-in-chief, 1 male, 1 female. They said, done. 1 in the global north, 1 in the global south. They said, done. Editorial board, 50% global north, 50% global south, 50% women, 50% men. They said, done. I said, nobody should be turned away because they can't pay the APC. They said, done. I said, now we're in business. That's how that journal got launched. And we published this. No, don't clap yet, please. Because you've not seen the outcome, okay? You've only seen the intent. Remember? Intent is worth very little. Because we're all well-intentioned, right? So we published our intent, and then 2 years later, we did the hard look at our math. Because that's when numbers don't lie, right? You have to look at the numbers. So that's a two-year progress report. Here are the numbers. 43 section editors from 21 countries, 3/4 women, 50% global south. Okay, our section editors are primarily women. You should see the Zoom meetings. I'm like the only male lurking in the corner there, okay? 700 academic editors, including some wonderful people in this room, 53% from the global south. We featured work from authors from 85 countries, with half the countries in the global south. we intentionally commission papers from people far away from here. When I say here, not Yale, far away from the global north. Because we know we always get into Lancet if we want to. That's not the people we want to be platforming again and again and again, okay? We've intentionally gone and invited papers from the community, from youth, from people in the field who would never be asked to write. This is one heck of a work. Can you imagine? You think this happened just by just dreaming about it? No. This is my biggest lesson in this 2 years journey. If you are not intentional, you gravitate back to the default settings in global health. If you're not intentional, I would have recruited all of you to be my editors. Because I know you, you know me. You invite people who look like you. That's what we do, right? 90% of the time, we lift the phone. It's like being at NEJM, New England Journal of Medicine, and commissioning a piece from Harvard. That's what we do in the normal course of things. So if you want to break that pattern, you got to spend much more energy than you would normally do. So diversity and inclusion doesn't happen by just dreaming it. You got to put an extraordinary amount of hard work. And we were delighted when this paper came out. This has got nothing to do with me. An independent study ranked us as the world's most diverse journal in all of global health. When I saw this piece, I'm like, I'm breathing again in my life. Because this is an external validation of what we've done. We can talk internally, but that's not the same as being ranked by an independent group. This is 3 years worth of hard work, to the point that I'm thinking of giving up, because it's taken that much out of me, right? And the minute you stop putting in this effort, it will revert back to where it does again, right? It will shift beautifully towards, in fact, for a while, we opened the portal for anyone to nominate themselves for the editorship. Guess who put in the nominations? Go ahead. Men? Where? Men from the global north were the first ones in. Because that's what we do. We are very aggressive. Even if we don't know half the things, we put something in. Right? And women will be third guessing themselves, am I really qualified for this? By the time they decide, the opportunity is gone. Men like, I don't even know what it is, I'm submitting my CV. Sorry guys, I'm letting you down today. I'm giving away some of our secrets. Okay, last few slides. Equity in authorship. We have done so much to come down on parachute science. All PLOS journals, okay? PLOS Medicine blew me off. They said, as part of PLOS Medicine commitment to addressing parachute science, we now require local researchers, be first or last authors of publications based on global research. This is serious progress, okay? The next time we get a paper from Botswana with not a single Botswanan author, we're sending it right back. Said, explain this to us. What is going on here, right? Think about this for a second. This has been happening for decades, and we're finally starting to ask questions here. And so you may say, okay, Madhu, this is all great. What the heck have you done? Ask me, okay? I'm hoping you will ask me because I have a slide there, okay? And not even in the last few years, for several years now, I'm no longer the senior corresponding author in any of my students' thesis papers. It is my co-PI in India, Peru, South Africa. I am no longer. Look at the papers. This is just to tell you that this isn't a figment of my imagination. Okay? So it is possible. If you wanted to lean out as the senior established PI, my thinking is, do I need yet another paper in my life at this stage? No. I don't need it. I don't care, right? But I want to make sure my colleagues in India or Peru feel like they have been recognized. The data came from there. They own the data. It's their patients, right? Training in global health can be completely reimagined. I spent the whole first hour of my global health course telling students what white saviorism is and what I don't want them to do. Okay, that's our Lancet piece. We've written so many papers saying we cannot continue to teach global health as if we know everything. How often have your global health courses platformed Global South speakers? Right? So I said, I'm not talking about AIDS anymore in Africa. I'm getting an African AIDS expert to talk to you. Why? Because Zoom works. Right? I totally changed how I teach global health thanks to the pandemic. At one silver lining of this pandemic is I'm no longer accepting that all the speakers in my course need to come from McGill. Okay? We can change a lot of how we do things. Global health partnerships. This is Sunil and Yap's paper. I don't have a slide here after this. I was just talking to Sunil. I want to know, give me one shining example of a truly bilateral, equitable partnership in global health. If you know any, let me know. I'll put it in the next version of my slide deck. Okay? Because I'm looking for case studies to show you. Allyship with local communities. Megan said this beautifully today. Somebody else said this as well in the day today. I genuinely think we look super disingenuous if we only want to get on a plane and travel 1,000 miles to do global health. If we continue to ignore inequities within our own countries, we have no credibility left. None at all. We have to do good by our own communities as well. It is not an either or. It is doing both and committing to doing both, right? And that's the piece that we wrote on global health, local, and look at that. This is 2 days ago in Lancet. Partners in Health, after working for decades in Liberia, Rwanda, Haiti, and Peru, are now doing community health worker training in America, right? They're doing the right thing. They have to use their talents also to serve rural, underserved communities in America. And lastly, funders. I think you and I will all instantaneously agree, if the funders don't change, this is all doomed. Why? Because you and I are so dependent on funders. So we wrote a piece, Samuel wrote a piece on institutional allyship. We have a whole set of checklists, just like the checklist that Yap and Sunil did for partnerships. We have a checklist for funders, okay? What should the Gates Foundation do? What should USAID do? What should Fogarty do? And they are thinking about it, okay? USAID has a localization agenda. Wellcome Trust is saying our grant making is not doing well by their own account. And so they now have funding calls only for Black researchers, only for Global South researchers. Fogarty, Roger Glass wrote a piece on decolonizing it. They're tracking it. I think our funders are finally starting to wake up, but I do not have a shining example to show you yet. I want to see a funder in global health who's genuinely moving money straight to Global South. Bypass me, bypass you, go where it needs to go so that we don't have to do this song and dance on how to pay them $50, right? Long ways to go, but some promise from all of the people that on the slide. And advocacy, I was talking to Christina yesterday, should this indirect cost not be better? How will they develop capacity if we keep giving them measly indirect costs, right? So I was pleased to see, again, Yap and Jessica's paper. All of you can and should convince NIH to do better, right? So please continue to advocate with your own funding agencies. Say, this is not an acceptable situation because their infrastructure will never get better if we don't do good here. And last comment, can you truly, truly make a change when all the power continues to be held in a global north headquarters? You can see there are many international NGOs. Headquarters is in Seattle. Headquarters is in DC. Headquarters is in Boston. Unless Boston signs off, nothing happens, right? So Anu Kumar, who heads an international NGO called IPAS, she wrote a piece, beautiful piece on white privilege in global health. Please look it up, Anu Kumar. She wrote the piece, and then she said, oh my God, what have I done now? Because I need to make a change as the CEO of an organization, right? It took her years, she did it. She decentered power away from the US office and shifted power to her country offices. And she says, that's the way to truly take power away and move them to where it needs to go. So you may say, are there good examples of this? I've been accumulating them. Compass, which is associated with the HIV group, recently said, we are decentering away from the US and moving the secretariat to Africa. Here is another organization, which was originally at the London School, is now moved to South Africa. This is intentionally being done. This is not an accident, okay? They're saying, if this is truly a global health organization, let it be headquartered in the Global South itself. So I'm accumulating more examples to show you soon. Last slide is, as much as I'm starting to give you some hopeful signs that one can make a change, like the journal, like these examples, I worry a lot about what's possible. Why is that? Look at our own culture of soft money in global health academia. We are all suffering because of this soft money culture, right? That's what makes us fight for scraps. That's what makes us hoard power, hoard money, hoard authorship. Our criteria for promotion and funding. Give me one institution that has a more liberal, thoughtful promotion criteria where you actually get a gold star for being an ally, where it's okay if you're not the first author. It's fine if you're a joint first author or a joint senior author. I pat you on your back because you did the right thing, right? University of York University in Toronto sent me their promotion criteria, where it clearly says, we are not happy if you are the first author all the time or you hold the money all the time. I'm like, damn, this is good. I need to now use that at McGill. I'm not sure they let me at McGill. I'm not sure they let you at Yale either, right? Because our promotion criteria are hundreds of years old. We hold on to it like our life depends on it, just like our authorship criteria. How often have we kept people away from the authorship list because they didn't check every damn box on the ICMGA criteria? So we've loosened that too. At PLOS GPH, we do not believe in the ICMGA criteria because it's too damn rigid. If people have contributed genuinely to your paper, please make them an author. You may not even be paying them much. At least give them credit for the hard work they put in, right? So just like human beings invented these criteria, human beings can change them. It wasn't given to us by God. The promotion criteria didn't come from God, nor did the ICMGA criteria come from God. It came from people like you and I. If we wanted to change it, we can change it, okay? So take some risks, do the right thing in your work. And I also want to say this. The last thing scares the heck out of me. You may be the most reciprocal person on the planet, but if your own government won't give a visa to the person you're inviting from Uganda or Liberia, what do? What do I do? I told you how disgraceful Canada was with the AIDS conference. So we've written a letter to the immigration minister, as I mentioned to you earlier, and they sent a 4-page reply back, okay? We have to put pressure on our own leaders to do the right thing, right? But with all the populist far-right governments that are there everywhere in the world, I'm terrified about your upcoming election, I'll be honest. Because it's not just your election, the whole world is watching it, right? And I'm terrified about my upcoming election in Canada. I'm scared about what's happening in India, right? Everywhere the pendulum is swinging far right. And the first thing they do is cut immigration, cut refugee programs, cut international aid. They do this with no hesitation. That's what we are up against, right? And we were discussing yesterday, I believe. Is it possible to do global health anymore without getting political? It's not. We saw during the pandemic. Everything finally is ruined or made by politics, right? So we have to figure out what this means. How do you show global solidarity in front of a leader who is absolutely far-right populist? How? What argument do you make to share vaccines or share IP? I don't know the answers, but I'm scared. Lastly, remember I told you, none of this makes any sense if you don't ask what the Global South people are doing or should be doing. And they are starting to write pieces of their own. This is a piece from India. And you know what they're saying? Yeah, we agree there is a massive power dynamic, global North, global South, but within India, it's the elite castes that dominate global health. I'm like, yes. When I gave this talk in South Africa, you know, they shut me down quickly and they started discussing among themselves. Somebody in the audience said, Dr. Pai, we have a global North and global South within South Africa. We want white South Africans to be better allies to black South Africans. I'm like, yes. This is the same discussion in India, except that it's caste, right? So decolonizing is not just the global North-South dynamic, but even within countries, what equity means needs to be addressed. Beautiful piece, one of the best ones that I've read, to say, my cynical way of thinking is this. as much as you and I will try hard here to shift power, okay, we know from the great Frederick Douglass, who said this decades ago, that power will not give up power ever. Privileged people will never give up their privilege. There has to be a demand for them to do so. And to me, that is what's going to come from the Global South. The Global South is one day going to say, we're done with you guys. We do not need you to solve our malaria problem. We know what to do, we'll take care of it. And when that happens, we will all have nowhere to go but to say, please, good luck with your work. If there's anything at all we can do, let us know. Because I don't see any other path for us. What has been happening all these decades is simply not working. Because if it was working, we wouldn't be in this mess that we are in. If none of this was enough to rile you up, I invite you to join this amazing set of people who will be giving a whole online course on reimagining global health. Okay? It's coming up very soon, next month. But just look at the lineup of people. Somebody, when I tweeted this, somebody said, this looks like a real global health course. Not just taught by those privileged of us in the global north, and this didn't magically appear. I intentionally went after every one of them and said, I want you to teach in my course, okay? We have a lot to learn and unlearn. More than anyone else, I'll be learning the most in this course. That's the number of amazing people I've invited from whom I want to learn about. So reimagining global health is not a static. It's happening. Every version of this talk I have changed as I'm thinking, as I'm trying to do something different in my career. And I'm so, so grateful to all of you, especially this amazing set of people. And I hand off to Sunil and Rosanna. Thank you.
Well, I'm tachycardic, hypertensive, and public health. After that talk, probably the last thing you want to do is hear me talk, and you want to probably hear Madhu talk some more. Absolutely inspiring. Just a quick reflective comments, and then maybe something that I hope you would address. One, just very quickly on the advancement and promotions, the authorship is so critical. Haven't done the best job in my career so far, but just thinking, I filled out the faculty end-of-year questionnaire for Yale, all of us here. I specifically asked how many first author publications, how many last author publications. So everything else, who cares?
Not relevant.
No, it doesn't matter. Right, so we can make some changes. The checklist was a really amazing experience for me, and I wanted to really highlight that it was two students that really came up with the idea. Yap was really the inspiration for it, but Daniel Hodson, who's a medical student here now at UCLA, and Yannick Mbarga, who's a Cameroonian student, it was really them together that started to have the idea of, at every step in the process, where can we think about equity? A lot of us kind of, I feel like an imposter in this a lot, where we are intending to do the right thing, but we forget along the ways because we're busy, but trying to remember at every single step in the process, just do a check. Have we incorporated our colleagues in an equitable way? Are they benefiting from the design, from the statistics, from the dissemination, from the money to go to the conferences? So actually having something on paper, but it was really the students that were the genesis, and I think it's really hopeful for the future. Walking down here, Madhu asked me, can you tell me one of the examples from where you work, where you've fulfilled the checklist? And my answer is no. There's not even close. So I think that's just the reality of the situation, but we're trying. I want to ask you questions about language. So language is important, both in how we talk about global health amongst ourselves and in our platforms. Something as simple but as hurtful as saying things like the third world. I still hear it. I hear it all the time. I hear it last week here at Yale. So just in terms of an allyship versus other ways we can talk about our partnership, I think there's importance, and I really appreciate how you highlight that in your writing. But I think the other aspect of language is the challenge that comes, now that I've been working in Francophone Africa, my colleagues are really held back by the inability to speak fluently in English, right? So it comes from not being able to write and publish in journals properly, not being able to comfortably speak in conferences, not being able to necessarily understand what's being taught, what's being spoken at conferences, or even what they can read. So I'd love to hear your thoughts on how to really make language more accessible, because if 50% of the board seats are the UK and the US, and the funding's all coming, it's English dominated, but that's structural inequity is going to make it really impossible to be truly global. So I wanted to get your thoughts on that.
Good afternoon, and in fact, thank you so much for such an inspiring talk. Much of what you said, we are speaking or preaching to the choir here, and the question is how to make the business case for the equity in global health. I also have a question about language. I represent the global South in Spanish. I'm coming from Latin America. And much of the work that is published is in English. ChatGPT can solve it. I was just in a meeting with friends. Someone asked me to translate a email that they were going to say, and a South American friend said, "No, you don't need her. There is ChatGPT," which was great to hear. So why we cannot do that, right? If a machine can solve that problem and many others, why we cannot do it? Thank you for that response. And the other response would be, how can we follow the money? Much of the investment in global health is many times fold what much of the people that we want to help make. And that is a tremendous inequity. So can we follow the money, please? Thank you.
So on the language front, all of you had a troublemaker called Christine Ingaruia here, right? Mm-hmm. So Christine was one of my section editors. She gave us hell over the language issue. So then she, along with all section editors, wrote a complaint to PAWS CEO saying that how can PLOS GPH be considered a true global health journal if everything is in English, right? So what we have, baby steps we've taken now is that we allow authors to translate into any language they want, the abstract, and we'll post it on the journal site as a supplement. That's easy. Other journals are doing it too. Lancet Microbe, for example, allowed us to translate into Spanish for a paper in Peru and post it. In terms of AI, the publishers are telling me that they cannot stand by the scientific accuracy of an AI translation. Imagine if the odds ratio is mangled, or if the words are not authentic in terms of what it is looking like. They say legally they cannot take responsibility and stand by what the machine translated thing looks like. I think those translations are okay for our everyday purpose. But for scientific purposes, journals want to know whether it's accurate in terms of what the English abstract says. I think it's soluble. And this is one area where I really want AI to help us. I'm nervous about many other aspects of AI. We are getting so many potentially fake papers submitted. We don't know who wrote them, and we have no idea what's AI and what's not AI anymore. Right? We don't even know if the authors are human. We don't know if the editors are human. I got critiqued that you rejected my paper based on a machine peer review. And I'm like wondering, what on earth am I supposed to do now, right? So all journals are running helter-skelter right now. None of us have clarity on where AI and how it can be used. There are tentative guidelines coming out. It's a fast-moving area. If the accuracy is very good, then I think AI is the right way to get translations happen in multiple languages. But in terms of money, I think money is where the real challenge lies. Changing funding flow if it can be done, will have phenomenal impact in how things can be done. All of you are following the funding model by McKinsey, what's her name? Former wife of Jeff Bezos. Scott. She is totally changing how to do philanthropy, right? So there are people who are creatively thinking about how to move money directly to impacted communities and bypassing all of this stuff. And I think we need some bold examples in the area of global health to inspire us. I've shared all of this with the Gates Foundation too. They invited me to speak on decolonizing global health to the entire Gates Foundation. Can you imagine the stressful time I've had? There were 500 Gates Foundation staff on the Zoom call. I was just absolutely terrified, okay? I'm not sure what they've done structurally, but there are people, I assure you, they're thinking about it. They're absolutely thinking about it. So is Fogarty. So is Wellcome Trust. Wellcome Trust has made big changes in the last couple of years. So it's possible, I think.
Madhu, can I ask maybe one more?
Yes.
One more quick. So we're in a position of privilege on the senior faculty side. I'm going to throw myself in there maybe generously, where we can be fine with being anywhere on a paper. How do we create a system where our junior trainees can be supported and encouraged to take those risks and be supported and rewarded for being an ally and not a
Great question.
second.
So
second
I get asked this question a lot. I would be very happy right now if just the senior established people started doing the right thing, because it's a low-hanging fruit. We do not need yet another first authored paper. We do not need yet another award. We don't need another plenary talk. I promise you. We have enough medals on our wall to last us for a lifetime. So I want to see us, so I'm including myself, to role model this for others, okay? And on the junior front, I've started creatively doing something which I discussed yesterday. We now take all 4 author positions. Joint first authors, Peruvian, Canadian, Peruvian. Joint senior author, Canadian, Peruvian, Canadian. So we count all of them as equal first authors, equal senior authors. So we now have 4 places that we can equitably divide 2 north, 2 south, which I think if we started accepting joint first and joint senior authorship as first authorship, as senior authorship, suddenly I think we have creatively improved the space. Is it perfect? No. But is it possible? You can do it tomorrow. I've done it, right? My Lancet Microbe papers, the 2 ones that I showed you, are both that. And Lancet Microbe gave me no hard time over this. None of them said a word, right? So let's come up with these creative things, and let's not ask for permission. We just do it, right? And if the pushback comes, we'll deal with it. Thank you.